Hey, good morning, good afternoon, and good evening to all of you in your respective time zones. I am honored and welcome you all to this vital discussion on overcoming language and cultural barriers in fertility preservation for pediatric and adolescent populations. My name is Anthony Kayiira, and I'm delighted to serve you as your moderator for this session. Today, we gather to address a topic that is not only critical in the realm of oncology practice, but also deeply impactful on the lives of young patients and their families. Fertility preservation is an essential aspect of comprehensive cancer care, offering hope and future possibilities to children, adolescents facing challenges on the journey of cancer treatment. However, the process of fertility preservation is fraught with complex medical, ethical, emotional, and other considerations, which are further complicated by language and cultural differences. These barriers can significantly affect the understanding, decision-making, and ultimately the outcomes of these young patients and their families. In our discussion today, we aim to explore the challenges in depth and to identify strategies to bridge these gaps. We have gathered a distinguished panel of experts who bring a wealth of knowledge and experience from various fields, including oncology, reproductive medicine, oncofertility, reproductive embryology, and medical interpretation. Together, we will delve into the multifaceted issues at hand, share insights from different cultural perspectives, discuss best practices, innovative approaches, and ensure that every child, regardless of their background, has access to the best possible care and support when they have cancer. Our presenters are Dr. Dana Kimelman. She's a specialist in reproductive medicine and oncofertility at Personalized Medicine, British Hospital, Reprovita Lab and Biobank, and Hospital Echeverria-Raddatz. She is also a reproductive medicine specialist at the Montevideo Infertility Center. Dr. Dana will provide an overview of health literacy in oncofertility. We also have Maria Echeverria-Raddatz. You'll forgive me for messing up the pronunciation because I'm not so good in Spanish. She is the medical interpreter at the Ann Robert H. Lurie Children's Hospital in Chicago, Illinois, USA. We have Dr. Barbara Lockart, a pediatric nurse practitioner at the Lurie Children's Hospital in Chicago. She works in both the fertility preservation program and the solid tumor section for hemato-oncology. We have Natalibeth Barrera, a clinical embryologist at the Centro de Estilad Montevideo in Uruguay. She will present resources and resource limitations for non-English speakers. Please feel free to ask questions and share your experiences and contribute to the discussion at the end of all the presentations. Our goal is to leave this session with a deeper understanding of actionable strategies that we can implement in our respective settings. Thank you for joining us today, and I look forward to a productive, enlightening discussion. We can begin with our first presenter, that is Dr. Dana. I'll stop sharing my screen.
Sorry. Hi, everyone. I'm sorry I was muted. Thank you so much for the invitation to participating on this webinar, which is a very interesting and so important topic. It is an honor for me to share the panel with amazing colleagues. I want to say that especially Barbara Lockart was an inspiration for me when I first attended an oncofertility conference in 2015. So it's an honor to see myself today in a panel with her. So I'm gonna talk a little bit about health literacy in oncofertility. I just wanted to mention that for people that are not familiar to South America or Latin American countries, maybe you can imagine that we are like the same, but we are very different countries, and especially we speak different languages. So this is very interesting and important because we have a lot of migration to our country, and we see people and we work with people and patients that speak different languages than Spanish, which is the language that we speak in our country. So for us, it is very important to talk about this and share experiences with all of you. So we also have different religions, cultures, incomes, and governments, but I wanted to put some emphasis on language. So why are we talking about health literacy in oncofertility? So health literacy, it's the ability of individuals to access, understand, and evaluate and communicate information related to healthcare. And these 4 words are like clue for having a good health attention. So it is very, very important to make sure that patients understand what physicians or health providers are saying and are explaining. And it's very common to see here in our country that patients are like ashamed to saying, I don't understand, I don't know what you're talking about, I need you to say that again. So why is this important? We need good health literacy. It's crucial to managing patients' health. So for self-managing, to make appropriate care choices, and this is very important in oncofertility, as you know, because sometimes we offer different options, and sometimes patients decide not to go through these options because they didn't understand and they're afraid to say, I didn't understand. So it allows patients to engage with preventive measures in order to protect their fertility, and it also promotes better healthcare outcomes and being able to communicate in a good manner, reduce disparities, which is very important and very frequent here in our country. So why is it important to understand language barriers? There are lots of language barriers in healthcare. As I was saying, there's a lot of migration. In the States, you see thousands of patients that don't speak English correctly. So it occurs when healthcare providers and patients don't share the common language, and this leads to difficulties in communication, also misunderstandings, which may cause problems on treatments for patients and for physicians and health providers. It may lead to medical errors and also lower patient satisfaction. The problem is that many patients that are like in worse situation or less resources, they won't say they are not satisfied, but that happens. The impact of language barriers on oncofertility patients, if there is a language barrier and we don't work to break it, oncofertility patients may not receive a quality care. They will not understand. Sometimes they will not understand the diagnosis and the treatment options and plans, and of course they will not participate actively of their decisions, and they won't understand that fertility preservation options sometimes are safe and they can go through them. They will say no because they don't understand. So it is important to break this barrier in order to make patients know that they have options. So I love this image from Northwestern because it's like that. I mean, if I understand how it works and I know what they're trying to say to me, I will know what I want. So how can we overcome these barriers? Of course, the role of interpreters and translators is very, very important. So they have an amazing role on this group of patients. Also providing translated materials and resources. There are a lot of websites that are translated to different languages, like Save My Fertility at the Oncofertility Consortium website, but also at the Oncofertility Consortium conference last November, Shiva Center from Israel. They showed an amazing resource they have, which is in YouTube, with like cartoons to understand for younger patients to understand what is fertility preservation, why it is important. So I recommend, if you don't know this resource, to visit this website. Also try to use culturally sensitive communication strategies, which is very important for all patients they will feel like included and that we are thinking about these patients. And also it is very important to simplify healthcare information. We always insist a lot of having leaflets on the physicians' offices. This makes a difference. They will see and they will understand what we are talking about. If there is a language barrier, if we have like a lot of drawings and easier materials for them to see. Education and awareness programs for patients, this is also very relevant. And another thing, which is the end of my presentation, but I think it's very important, and there here in our country, which is Uruguay, we have a very important barrier, is that having the time to communicate for healthcare providers and patients. We have here, usually in many institutions, only 20 minutes per patient. So that's not enough for a patient that has a language barrier to understand everything we're trying to say. So we need to dedicate time for this group of patients and be able to make sure that they understand what we're saying in order to feel okay with what they will get and understand. So this is all I have. Thank you so much. And I'm open to questions at the end of the webinar.
Thank you so much, Dr. Dana. Now we shall have the next presentation by Barbara Lockart and Maria. Let me share my screen.
Thank you so much, Anthony. It's a pleasure and an honor to be here. I'm Barbara Lockart. I'm a nurse practitioner at Lurie Children's, and I've had the fortune to work with the Oncofertility Consortium organization really since its inception. I also have the honor of sharing the screen with Marianne Echeverria-Raddatz, who is our medical interpreter here at Lurie Children's and the oncology department. And so she has been utilized for many years in fertility preservation discussions. And I thought that we really needed to have her present and get her insight into the challenges that some of our medical interpreters can face when we're asking them to do this. So thank you. And next slide, please. So Dr. Kimelman did a great job of outlining that every country we have many different languages. We live in a global society and there are hundreds and hundreds of languages. But I think the other thing that's really important to understand, that on top of hundreds of languages, is there can be different dialects and there can be different customs even within a shared common language about how we approach things. I think if you're in Haiti, French is, yes, the official language, but Creole may be the language that your patients are speaking. If you're in Ecuador, Spanish is the given language, but you may be up in the Andes and Quechua may be the language that your patients are learning from. And next slide, please. Thank you, Anthony. I think another important piece of this is also recognizing, first of all, that medical information is considered a patient's right. We have an obligation to provide them information. It's in the US, not only a legal obligation, but our accrediting bodies, such as Joint Commission, we have advocacy groups, and then the Medical Interpreters Association is an advocacy professional organization that advocates for our patients getting information really in their preferred language. And I worked with several nursing organizations recently to develop a fertility preservation position statement. And one of the key pieces was that our patients need to get information in their preferred language. And what do we mean? That means that it's not the language that I think that the patient should receive information in, the one that I believe that they should be fluent in, but the one that they tell us that they want to hear information in. And that can sometimes be challenging in pediatric patients. We're working with a family unit, and you may have an instance where the parent or parents are more comfortable in their home language, their native language, but the child, the patient, has been integrated here into the US, so now their preferred language may be English. So we're providing information twice, which is very important. I think it's also important to realize that medical information is also a literacy issue, and that you may have families where the parent or the child is not able to read. Their reading comprehension may be third grade level, maybe fifth grade level. We are presenting very, very complex information. And so that we need to be able to provide information in multiple ways. And I think that that's why with this type of a conversation, really having a dialogue with the patient and the provider and the medical interpreter is so important. So next slide, please, Anthony. So we know that there are some language services. When I first started working here at Lurie, I made the error of calling one of our interpreters a translator, and I was corrected appropriately, as I should have been. Interpreters typically work with the spoken word, and the dialogue, it moves in two ways. Marianne and I, or actually sometimes three ways, because Marianne is also very good at miming what I'm doing when I'm talking to families. She has expertise in HEMONC, so they often have expertise in one area, and they may do simultaneous or they may do consecutive interpreting. I have a very hard time with simultaneous interpreting, so I have to feel comfortable when I say to my interpreter, I realize this slows you down, but my brain can't process words coming out of my mouth and hearing you say them at the same time. And they clearly have to be fluent in the language of the patient and the provider. Translators are typically written word. So if we have legal documents, consents that we need to be put into a non-English language, we have our translators do that. Communication is one way. And again, they often have expertise in one discipline, you know. So yes. Next slide, please. So go ahead. Do you want to? Yeah.
Oh, you do this?
No, go ahead.
Well, hello everyone. My name is Marianne Echeverria-Raddatz, and I've been working at Lurie Children's for 9 years, 8 years with hematology and oncology. And it's always a pleasure to work with Barb. We have a very good team. We know our families, and we work together very, very, very well. So who is not an interpreter? Family members are not interpreters. They are not certified. I'm certified by CCHI, which is a National Medical Interpreter Certification. And family members are not supposed to, unless it's an extreme situation that the interpreter is not around, but family members are not supposed to interpret because they are not medical staff. We have at Lurie Children 13, almost 20 interpreters, Spanish interpreters, and then we have also video interpreters and phone interpreters. The staff members are responsible for caring for the patients. So we are just a breach of communication. We are neutral interpreters. We are not supposed to give our opinions. We are just a way, like in the middle of two parties. So we understand what the provider is saying. We understand culturally the family too. So we are the breach of communication. We cannot give our opinions. We can advocate sometimes culturally for our patients if we see that there is something important that the provider needs to know and the provider didn't see. We can let the provider know. But yes, please, next slide. Anthony, thank you. The interpreter's role is we navigate culturally because we know the culture. I'm from Spain, but I'm Hispanic, so I can navigate culturally and know what the family might know or might think about fertility preservation is, for instance, is kind of a shock for our families. But the providers, I always say in Spanish what the provider says in English. So I'm not supposed to add anything else. I can clarify if I know even that the provider didn't understand something that the family said or the opposite. We are just basically part of a conversation. We are like right there in the middle, and we are part of a very, very difficult diagnosis and very difficult situations and decisions and options. So how can we improve? We can, it's very important to make the family understand what the diagnosis is, because the diagnoses are very, very difficult to hear what they are going to go through. And then we utilize all types of services here. You know, at Lori, we have all types of services. Families are very well taken care of in that respect. And we also, we need to improve the patient satisfaction. I mean, when we hear that families that they thank the interpreter for you know, having understood, or they make the family understand something so difficult, like it's a diagnosis, or like it's any type of like options, because they are going to go through chemo, and then the kids are going to go through chemo, and then we need to tell them about fertility preservation, which is a shock. So next slide, please. Yeah, Barbara and I, and with other providers too, we talk and we speak, we work very well together, because she pauses, you know, as an interpreter, I'm supposed to be very exact and very accurate when I deliver interpretation. So if doctors speak in long paragraphs or long sentences, is difficult because we are summarizing. So we do consecutive in the medical field, consecutive interpretation, unless we are in a care conference, like an end of life or a care conference, or even a trauma. We have to use simultaneous. There are many doctors and providers who don't like simultaneous interpretation in a medical setting, because as Barbara said, it throws them off. It's like they cannot hear themselves what they have to say. And also the interpreter is talking and the family is talking. So there has to be pause and order to be able to have a good encounter. We avoid medical jargon. Medical terminology is it has usually a Latin root. So for Spanish people, it's easy. For me, it's easy to figure out or find out the meaning of maybe some medical term that I was not familiar with. So, and then always we are neutral. We are there, but as interpreters, but it's like we have to think that is the same as if we were not there. It's like the conversation. There is eye contact, of course, because sometimes we don't understand things, or the family is like, I know they didn't understand something, so we need to clarify. But the communication must be between the provider and between the family. We are just a voice there. We observe like different cues, like different hints, different things from the family. Just when they move their eyes or their hands, so I know, and even with the provider, same thing. We are interpreting everything that is around us. It's very important for the interpreter to be told, like before the encounter, before the session. Barb does it very well. Like for instance, if it's a new patient, they give you like a little insight, a little heads up. It's like, well, this patient has this diagnosis, and then you know, they are going to need the chemo that the child is going to receive, and needs, you know, we need to tell them, give them more information about fertility preservation. So we try to do our best for them to understand such a difficult topic, because it's a shock sometimes. It doesn't matter if the family is American or is from Mexico, it doesn't matter. Maybe culturally, maybe Hispanic families are more like, what are the doctors talking about? What is happening? What is going on? But the providers explain very well, first, the biology of the topic, so they know more or less what to expect, and they give them options. They don't force any family to do this or to do that, so the family freely can decide what to do. And debrief and offer support to the interpreter as needed. Yeah, well, the interpreter, we go through a lot. It's a kind of a bittersweet job. I love what I do. I love oncology and hematology and oncology. I see the families mostly like even when they are first diagnosed in the ED, the kids are vomiting, the kids have a headache, they have blood work done, and then they are, there is something wrong. There is a leukemia, there is some type of tumor. Then, so I know them once they are in oncology, and I help all the doctors, APNs, chaplains, social workers, therapists, all of them, when they are working with the family. So it's not just, but yeah, the oncology part of the oncology preservation is a very interesting topic that I always try to follow what Barb says, and explain it in a way that the family is going to understand. Next, I don't know if there is another one,
So I'm very fortunate to work with Marianne, and our division is very fortunate to have such a skilled interpreter. And she is a valued part of the team. As you can see, we have a lot of mutual respect. And so I do think it's important to value what they say and to acknowledge their grief and their sadness when we're dealing with these patients, and realize that it is often a heavier burden for them because they're carrying the weight of both the provider's communication and the patient's communication. And that can be really heavy at times. And the last thing I'm just going to close with is, we as providers need to examine our own discomforts and biases and how those impact the communication that we are bringing to the table. And so we all need to think about our sexual identity, our comfort with that, our own personal religion, and cultural awareness. I think it's good to not be shy about asking questions if you don't understand something. I never make assumptions about somebody's motivation to do fertility preservation, or any assumptions about cost or ability to pay for anything that we do. And I think the other thing too is that the other burden that is on the interpreter is, just as providers have to have for developmentally appropriate conversations with our patients, so do our providers have to figure out, and our interpreters figure out, how we navigate that, say when we're having a conversation about doing testicular tissue cryopreservation in a patient who's 6 years old. So all of that is very important to the success of caring for our patients. And Marianne and I are happy to answer any questions, and we appreciate your time.
Thank you very much, Dr. Barbara and Maria. That was very insightful representation. We shall have our next presentation by Natalie. I'll stop sharing my screen. Natalie, you can start sharing your screen.
Sorry, I was mute. So thank you very much for inviting me to this webinar. As you know, I am an embryologist, and this is not my area of expertise, but I was very happy of learning more about this topic and share with all of you. So, limited English proficiency individuals refers to anyone above the age of 5 who report speak English less than very well, as classified by the US Census. About 25 million in US were considered limited English proficient in 2013. Thus, the most lived individuals are immigrants. Nearly 20% of the population was born in US. Overall, the LEP population represents about the 8% of the US population. LEP individuals face challenges in accessing high-quality healthcare, as mentioned before by the other speakers. Medical errors are more likely to cause physical harm to LEP individuals than to English-speaking patients. Knowing that, it is very important to us to understand the demographic and create policies and good services for this population. As mentioned before by Barbara, the Title VI of the Civil Rights ensures that LEP population needs to be protected for discrimination. The Office for Civil Rights has the authority to investigate complaints from this population and withhold federal funds related to linguistic access. Also, this was revised again in 2000, and this order mandates that all healthcare providers receiving federal funds, including Medicare and Medicaid, they should review and assess the policies to ensure meaningful access to services for LEP population. In 2013, around 61.6 million people in US, both foreign and US born, spoke a language other than English at home. Of these, about 41% were considered LEP individuals. As we can see in the graph, between 19 and 2013, the LEP population grew by 80%, rising from nearly 14 million to 25 million. And this percentage is maintained during the time. The growth rate is low in 2000, as we can see in the graph, and the LEP population has since stabilized. Compared to the English proficient population, LEP individuals were less educated and more likely to live in poverty. Additionally, LEP men were more likely to work in construction, natural resources, and maintenance occupations, while LEP women are more likely to work like in housekeeping, laundry services, and personal care occupations. The higher concentration of LEP individuals are found in California, Texas, New York, Florida, Illinois, and New Jersey, and together account for approximately 2/3 of the LEP population in the US. About 64% of the LEP population speak Spanish, followed by Chinese, Vietnamese, Korean, and Tagalog. The Hispanic population in US is currently about 15% of the population and is expected to grow to 24% by 2050. So this is very important to know because we need to be prepared for this population for taking care of them in our health services. Also, it is very important to know that linguistic diversity among the LEP population also differ across different states and countries. For example, in New York, they have a high number of Spanish and Chinese people, but in Maine, they have primarily people who speak French. In terms of demographic, LEP individuals were less likely to be of school age and more likely to be of working age, as we can see in this table, falling into our target population in terms of fertility preservation. As we know, individuals with limited English proficiency face challenges in interacting effectively with healthcare providers, increasing the risks of health and healthcare disparities. By another hand, language concordance between patients and providers improve health outcomes, patient satisfaction, and overall hospital experience. Reducing the emergency department visits and costs, and decrease physical harm from adverse medical events. A good article that described the health disparity in the LEP population was done between November 2021 and June 2022. 144 hospitals located across the US participate in this study. Using a standardized script, train investigators assigned to the role of English-speaking, Spanish-speaking, or Mandarin-speaking patients. They call the hospital the general line in the hospital, seeking for access to care related to different 3 types of cancer that are very common in the Hispanic and Asian population: colon, lung, and thyroid cancer. And then the outcome evaluated was if they were provided with the next steps to access cancer care. It's mean or defined by they were provided by a clinical number or a clinical transfer to another department. So the call was transferred to another department. About the 52% of the callers were transferred to access cancer care, but callers that speak Mandarin or Spanish was less transferred or were less likely to be provided with the next step, as we can see in the graph. Mandarin was 27.5% and Spanish 37.7%. The author conclusion was that linguistic disparities exist in access to cancer care for non-English speaking patients. As we know, there are many barriers to fertility preservation in the US, and these are pretty known by everyone here. But additional to these barriers, immigrants face another kind of barriers, including finding a physician, legal status, and language limitation. LEP individuals often encounter barriers similar to those identified in the general population, such as lower health literacy, as mentioned before. Also, they have less access to health care information, and also they have socioeconomic constraints. However, it is important to mention that majority of the LEP population have low-wage jobs that often do not offer health coverage, contributing to higher insurance rates. This highlights the critical need for healthcare systems to address language and cultural barriers to ensure equitable healthcare access for LEP individuals, although from low resources settings. It is important to mention that the median earning of English proficiency workers are 39% higher than LEP workers. As we know, there are many materials available for non-English speakers. Printed material normally is prepared by professional healthcare staff who use special translation services. However, we have, if we are a patient and we are looking in Google information, we know we have this Google translation option, the icon on the screen, but normally the Google Translator is not trained for medical translation. This can lead to inaccuracies or confusing translation in medical context, where we know that precision is crucial. Translation can lose clinical context. We may change the original meaning of the text. Mistakes in translating medical information can have serious consequences for patient health. Similar limitation applies to video resources like YouTube captions, especially when it comes to medical content. So it is important that for medical content to use professional translation and caption services to ensure accuracy and clarity of the information to our patients. But also we need to know that the first resource available for our patient are these online resources. And it's normally for them go and use these options of Google Translation or captions in YouTube videos. And we have to be aware of that. As mentioned before by the other speakers, health system can improve language access to patients by offering medical qualified interpreters who speak the patient's language. Service should be offered by telephone interpreting, video remote interpreting, multilingual support for telehealth, on-site interpreted, but also we have medication instruction and patient education materials to be translated. However, we have to keep in mind that the population often have less access to technologies. And this is also attributed to economical barriers, educational barriers, linguistic barriers, and digital literacy. These are some of the resources available. Some of them with the limitation that I mentioned before, that sometimes we have to use Google translators to see the information in another language. And finally, the challenge faced by the population in access fertility preservation are lack of multilingual information resources, difficulty in understanding medical terminology and procedures, and of course, limited insurance coverage for left individuals. And the possible solutions are provide multilingual education material, employ bilingual staff interpreters, offer a financial assistance program specifically for this kind of population, increase training for healthcare providers, and expand access to specialized fertility clinics in these diverse communities. So the home message is breaking language barrier is essential for delivering high quality care. As usual, and for all the language around the world, communication is always the key. So thank you very much, and I will stop sharing the slides.
Thank you so much, Natalie. That's a very insightful presentation. Right on the clock. It's now time for questions and answers. Any member from the participating audience can either direct a question to one of the presenters or leave an open question. You can ask directly by raising your hand, or you can type your question under the Q&A tab on Zoom.
Maybe Gina can go first, and then I would like to ask a question to Barbara.
Okay.
Maria.
Gina, you can go.
Thank you. I'll lower my hand. So I'm at a community hospital in a primarily a Caucasian area, but every once in a while we will get someone who is Spanish speaking. We also had someone who spoke Dari recently. What we do right now is we use video interpreter or just voice interpreter. So I have a couple of questions about that. What would be, okay, so when Maria was talking, she was saying, have a side conversation at first, letting the interpreter translator know what the conversation is going to be about. My question is that okay to do with a video interpreter? And do you tell the interpreter, inform the family that we are going to have a side conversation at first? Like, what's the etiquette? Because I mean, even if there's like a pamphlet of etiquette for this, that would be really, really helpful. I don't know if anyone has something like that. Just like translator etiquette as well. Those are two different questions in the same. Sorry.
I think Barbara and Maria can take that on.
Yes, it's more difficult if you are using a video interpreter because the provider usually is there in the room with the family already. So there is hardly any time to give the interpreter some insight or some heads up about what the conversation is going to be. And if in the case that if you are using an in-person interpreter, that's different because before going in the room, the provider can tell the interpreter this is going to be a little complicated, it's difficult, mom and dad are not really accepting what is going on. So the interpreter is ready to know like more or less how to interpret in more like detail or more, always following what the provider says. I'm not saying that we cannot make up words or we cannot say things or summarize too much, but if we know it really helps us a lot.
Gina, I actually, my preference is always an in-person interpreter, and then I have found my experience has been telephone interpreters are better than the video interpreters, and I don't know if that's your experience also. I will say to them, this is the conversation that we're having. I work in oncology. This is going to be a conversation about medications, or this is going to be a conversation about surgery, or this is going to be a conversation about fertility preservation. There have been several times, not with Spanish families, because we have a lot of Spanish interpreters here, but I can think of a Russian family that we had an interpreter with, and another family that was Arabic, and the teenagers said the interpreter's not interpreting what you're saying, which is an interesting twist on things because we don't want those patients to be acting as interpreters, right? But they were clued in enough to know that the interpreter wasn't correct or wasn't the patient's interpretation was that our conversation was not being interpreted. So I have ended conversations when I didn't think it was going well. I understand enough Spanish to really embarrass myself, but I can also tell when I have a phone interpreter where I get the sense that what I'm asking them to interpret is not being interpreted, and I will stop the conversation and say we need to find a different interpreter. But that takes a fair amount of comfort with the language, because I have much better hearing, understanding of medical Spanish than I do conversational Spanish. And I don't know if that answers your question at all.
Yes, it does. I usually use video, but can you tell me your reasoning for rather using just verbal?
I have found
telephone?
that the quality of the interpreter is better than but again, I mean, I don't know which service we use, one versus the other. And it could just be my comfort because we use more telephone. We have a longer history of using telephone interpreters, so that might be my bias towards that. Clearly if you have somebody who is deaf and you have to use a sign language interpreter, then we're using video.
Thank you very much, Barbara, for answering that question, Barbara and Maria. I think Dana had a question for...
Yeah, I was wondering, Maria, how many translators do you have at Northwestern? Do you have translators from different languages? Because I understand you speak Spanish, maybe you also speak different languages. I was wondering, and also, and maybe you can answer both questions at that time. I wonder if you only have this language barrier limitation. You have a lot of patients like with very, very little resources that you have, like, it's very, very hard for you to make them understand, or that's not frequent at Northwestern? Because I left Northwestern in 2018 and I wonder what's the situation right now.
Well, you are referring to translators or to interpreters?
Sorry, interpreters.
Interpreters. Okay. Well, interpreters, I mean, we have here at Louis like around 20 Spanish interpreters. Then we have dedicated interpreters like myself. I do hematology and oncology. Then we have in the ED department another dedicated interpreter. ENT also has its own, and the OR. And then the rest of the interpreters are working all over the floors. It can be psych, can be GI, can be adolescent medicine. So the number of interpreters at Lurie Children has grown because of the needs.
Yeah.
Providers need, like maybe because they are used to us and they work with us very well, they are used to having in-person interpreters. So when, for whatever reason, I'm not available, or if I'm doing a stem cell consult and it's a 2-hour session and I'm not available for Barb, she'll call me and then I'll tell her, you know, use the iPad, use the phone, or let me see if I can tell my dispatcher to send you someone in person, because there are providers that really, really want in-person interpreters.
So we have 2, I think, Arab interpreters. And it's been an interesting shift because I've been here 22 years. And when I started, the whole time we have a large Spanish speaking Latino population here at Lurie. But when I started 22 years ago, we had a dedicated Polish interpreter because we had a large number of Polish bilingual families. And that has shifted now, and we don't have a Polish interpreter anymore because we don't have the need. And now we have Arabic speaking interpreters. If we know that it's going to be a challenging conversation, say, you know, end of life or new diagnosis talk, we can get in-person interpreters for other languages, say, you know, Cantonese or Mandarin. So one of the things I like about Lurie is that we recognize that we have a very diverse population, and we do really everything we can to make it work.
Yes, and also I would like to say that if Lurie also, family services or interpreting services, our department works with different agencies. So we have a language, like a dialect, like Aguacateco, which is from Guatemala. And those interpreters, those sessions are requested in advance because there are not many interpreters of those dialects or those languages. And we, as Barb said, we have an Arabic interpreter for the whole hospital, and she usually does like, she's in the international department because we get lots of patients from Abu Dhabi and, you know, from those countries. And so it's domestic interpreters and also international interpreters who come to Lurie for like a complex decision, a complex treatment, and they come here and they are here for a long, long time, and they request interpreters like in person. No? And when the in-person interpreter is not available, then we use, or they request like agency interpreters from outside the hospital.
Good. Very interesting. Thank you, and congratulations.
Mm-hmm.
Thank you so much for that very insightful answer, Barbara and Maria. Do we have any other questions? I think there is a question in the chat. Are there any educational materials describing etiquette for providers to use? That would be going for Maria or Barbara. Is there like a website or?
For tips for medical personnel to be successfully utilizing interpreters?
Yes.
Yeah. I found that website that I said in our section of notes to be very helpful.
Okay.
let's see, I'm just pulling up or looking at our slides right now. The International Medical Interpreters Association was very helpful, and the National Council on Interpreting in Healthcare. Both of those websites were very, very helpful. Just in prepping for this. So I would recommend that people look there as a starting point.
Mm-hmm. Yeah, there is there are lots of like websites and on portals, different things that providers or the hospital or can go to, and in the specific department of language services, it's I mean, it's very wide, and it can because it's so important to provide with the first language of the family, give them the information they need. Because as we were saying before, it's the diagnoses are very hard, are difficult to hear for a family. So they need good interpreters. They need people who can understand them culturally too, and explain to the providers how the family is feeling, or how, you know, like a fertility preservation, like, you know, the girl is gonna get a chemotherapy medication that is gonna affect her ovaries, her fertility in the future. So that's so hard to hear when the patient may be 6 years old, and then, you know, this is gonna happen in so many years. So the family are trying to process now the diagnosis, and then on top of that, they are telling the family that the girl might not be fertile in the future, but we have these options that are investigational. So it's difficult. It's so difficult. So a good interpreter that sympathize with all this situation and understands everyone, I think, is so important in situations like this.
Okay, we shall have one last question from Natalibeth, and then we shall close the webinar. Natalie?
My question is these services of interpretation have an extra cost for patients?
Sorry, can you restate that?
My question is interpretation has a cost for patients?
Oh, no, not at all. That's it's a part of the hospital pays for it. In my case, you know, when the interpreter is dedicated to a specific area, oncology in this case pays for the interpreter, but in person is part of the interpreting services department gets paid by the hospital. And if we use interpreters, if the hospital uses interpreters from agencies, also the hospital pays for it. So it's it's free of charge. Families, you know, they don't pay for interpreting services, no.
And unfortunately, we can't bill insurances when we need these services, which is really unfortunate because it is a health equity issue. Everybody has a right to this information, and it's one of those things, to me, just like other things, other services we provide families, we should be able to bill for it. But that's my ideal world.
Yeah.
Okay, thank you so much, our very knowledgeable presenters today. That is Dr. Dana, Barbara, Maria, and Natalie. Thank you so much. And I think it has been an insightful discussion. We will be closing. The interaction can continue on emails, because I think we have the Education and Outreach Committee. And tomorrow we'll be having the semi-annual meeting for the PSC committee of the Oncofertility Consortium, which will be at 12 p.m. Eastern. Please endeavor to attend. Great discussions to have at the platform. Thank you so much, and good morning, good afternoon, and good evening to you all. Thank you.
Thank you.
Thank you.
Thank you, everyone. Bye-bye.
Thank you.